Hi guys, welcome to another lecture in the series Medicinal Chemistry 2, and today we're going to be talking about drugs affecting the GI tract, motility, and secretion. So we're going to be talking about the reciprocal relationship between the digestive system and drug therapy, because some medications they cause GI symptoms and some GI disorders alter how well the body absorbs and metabolizes drugs. So in terms of drugs that affect the GI tract, they include laxatives, antidiarrheals, your drugs using acid peptic disorders, and I skipped over the ones used for vomiting and nausea, and your cholinergics, which of course are drugs capable of producing or altering or releasing acetylcholine, and you have your anticholinergics, your corticosteroids, as well as your anti-infectives. So let's look at some organs and some associated disorders. So in your oral cavity, you could have stomatitis, and in your esophagus, you must have heard of GERD, which is gastroesophageal reflux disease. In your stomach, very commonly, you have peptic ulcers, gastritis. And in your small intestine, a lot of people suffer from malabsorption and an inflammatory bowel. In your large intestine, diarrhea, etc. Right? So we have all of these disorders associated with particular parts of our GI tract. So we're going to be talking briefly or a little about parietal cells. So I just wanted you to have an idea of what they are, or where they are. So your parietal cells, also known as your oxyntic cells, are epithelial cells in the stomach that secrete HCl or hydrochloric acid and intrinsic factor. So here we have our stomach and of course our esophagus and our duodenum. And if we take a cross section here, then we can see that, this red dot, when we talk about the parietal cells, these are the cells that we're talking about. So there are other cells that surround these parietal cells. So we just want to have a general idea of where it is and what is beside, etc. All right, so there are certain cell protective mechanisms in the stomach. For example, secretion of mucus, and as we saw here, there are some mucus, neck cells, etc. So you have secretion of mucus and bicarbonate. So as you know, this is your bicarbonate ion. We know that it is on the basic side of things. You have dilution of gastric acid by food and secretions. You have prevention of diffusion of HCl from the stomach lumen back into the gastric mucosal lining, and it's important to have your prostaglandin E, your alkalization of gastric secretions by pancreatic juice and bile. So let's talk a little about cell destructive effects on the stomach. Well, you have your gastric acid, which is secreted by your parietal cell, which we just mentioned. Your parietal cells contain receptors for acetylcholine, gastrin, and histamine, all of which stimulate gastric acid production. And acetylcholine is released by the vagus nerve endings in response to stimuli such as thinking about food. Some of us can attest to that. So continuing on these cell destructive effects, gastrin is a hormone released by the stomach and duodenum in response to food ingestion. So it affects parietal cells, which in turn causes gastric acid to be released in the stomach. Now, histamine, and we're familiar with histamine, is released from cells in the gastric mucosa and diffuses into nearby parietal cells. So we have the histamine here from our endocrine cell being produced and then diffuses into a nearby parietal cells and have, a similar effect. And you also have pepsin, which is an enzyme, proteolytic enzyme that helps to digest protein foods and also can digest the stomach walls. So before we go on any further, let's do a quick check. List the 3 endogenous chemicals cited that stimulate gastric acid production. Any thoughts? All right, well, they are gastrin, acetylcholine, and histamine. So if we look at this image here, we see acetylcholine, gastrin, and histamine. And if you can see, the arrows are all pointing into the direction of stimulating the production of acid. All right, so moving on from there. One bacteria that we need to mention is your Helicobacter pylori, or H. pylori, which is what I'll refer to it as of now, is a gram-negative bacterium found in the gastric mucosa of most patients with chronic gastritis, which is inflammation of the stomach lining. Right, so in 75% of those with gastric ulcers and 90% of patients with duodenal ulcers, this bacteria is present, and they spread by oral fecal route or by iatrogenic spread, and that is through a medical procedure or treatment such as blood transfusion, etc. And they are thought to affect mucosal function. So this bacterium is found in patients with these issues or otherwise. So we have a cross section here of the stomach, as we saw previously, and we see our parietal cells and our other cells as well. All right, so PUD, peptic ulcer disease, and they are gastric ulcers, and they are associated with stress, NSAIDs, and I'm sure you know your NSAIDs, which are your non-steroidal anti-inflammatory drugs, and there are several brand names, and you might know aspirin, ibuprofen, those are 2 common ones. They are manifested, so these ulcers can be caused by stress, NSAIDs, or H. pylori, and they're manifested by painless bleeding, and they take longer to heal than duodenal ulcers, and they are considered to be chronic. So for duodenal ulcers, they occur equally in men and women. They're manifested by abdominal pain, they're associated with cigarette smoking, and they're also associated with NSAIDs and H. pylori. So peptic ulcer and acid reflux disorders, well, it's characterized by ulcer formation in the esophagus, the stomach, or duodenum. And I have an image on screen here which kind of shows a puncture in our duodenum or ulcer, and it could happen in our esophagus as well. It occurs in areas that are exposed to gastric acid and pepsin. Gastric and duodenal ulcers are more common than esophageal ulcers. Parietal cells contain receptors for acetylcholine, as we saw in the image earlier, and the implication of which is stimulation by or of the vagus. All right, so in terms of upper GI disorders, you have gastritis, and that is acute or chronic inflammatory reaction of gastric mucosa. Usually we'll see peptic ulcers with gastritis, and non-steroidal anti-inflammatory drug gastropathy, which is stomach diseases, they occur with damage to mucosa by acetyl salicylic acid or aspirin or other NSAIDs. So chronic ingestion causes irritation of the gastric mucosa, inhibits the synthesis of prostaglandins, and increases the synthesis of leukotrienes and other substances that can cause mucosal damage. So in terms of selected upper GI disorders, we're talking about stress ulcers, and a very rare Zollinger-Ellison syndrome, which is excessive secretion of gastric acid and high incidence of ulcers. So as we see in this diagram here, the red represents the ulcer formation, and essentially the syndrome causes increased ACL, and that causes an increased presence of ulcers. And it's caused by gastrin secreting tumors in the pancreas, stomach, or duodenum, and it's often malignant. All right, so GERD, right? Most common disorder of the esophagus, characterized by regurgitation of gastric contents into the esophagus. It occurs most often after a meal, and it's worst when it returns, caused by incompetent lower esophageal sphincter. So here is the image of that: a healthy stomach and a healthy closed sphincter. And in the presence of GERD, the sphincter it opens, allowing a reflux. So the gastric acid gets a chance to enter your esophagus and causing GERD. So foods that cause relaxation, that is relaxation of the sphincter, is, they're listed here, and there are a number of them. GERD occurs in men, women, children, and it's very common during pregnancy. All right, so let's look at the classification and individual drugs. So the first type of drugs we're going to look at is antacid, and these are alkaline substances that neutralize acids. So raising the pH inhibits conversion of pepsinogen to pepsin. So here we have an image here of it, in your one of these cells you have pepsinogen or zymogen, right? And in the presence of HCl, you have conversion to pepsin, that is from pepsinogen to pepsin, which is your active enzyme which breaks down your dietary proteins to your digested or partially digested proteins, right? So antacids, they raise the pH level and inhibits the conversion of pepsinogen to pepsin, because acid is important in the conversion from pepsinogen to pepsin. Commonly used antacids are aluminum, magnesium, and calcium compounds. I have an image here of one particular brand of it, and if we can look at the active ingredients, we see here aluminum hydroxide, magnesium hydroxide as being your antacid. So antacids vary in onset of active and dosage needed for neutralization. Aluminum compounds require large doses for effectiveness. They can cause constipation, etc. Magnesium-based antacids have more rapid onset than aluminum, but can cause diarrhea and hypermagnesemia. And clearly that is too much magnesium. Calcium compounds can cause hypercalcemia and hypersecretion of gastric acid, right? So you can have too much of these elements if you could take too much of the antacids, obviously. All right, so simple question here. What is the formula for aluminum hydroxide and magnesium hydroxide? Like, write it chemically. All right, so if this is what you had, then you have the right answer. All right, so continuing our conversation about H. pylori, one of the problems relating to anti-ulcer therapy, both with H2 hydrogen 2 antagonists and the PPIs, which are your proton pump inhibitors, is the high rate of ulcer recurrence once the therapy is finished. The reappearance of ulcers has been attributed to the presence of the bacteria that we mentioned, the microorganism called H. pylori, which is naturally present in the stomachs of many people and can cause inflammation of the stomach wall. So we can see an image here, your stomach contents at pH 2, and then at a higher pH you have the bacteria H. pylori here in your mucus layer. All right, so as a result, patients who are found to have H. pylori are currently given a combination of 3 drugs: a PPI to reduce gastric acid secretion and 2 antibacterial agents, and we have a few here to eradicate the organism. So a PPI, and so we're going into the reason for this therapy. A PPI is administered because the antibiotics used were best at higher pH levels than those normally present in the stomach. And so the combination of omeprazole, which is your PPI, and your antibiotics, amoxicillin and metronidazole, is frequently used, but other combinations have been used as well. So this preparation has a toxic effect on H. pylori and may help to prevent adherence to the mucosa, as we see it adheres to it. Other protective properties include an enhancement of local prostaglandin synthesis, a coating of the ulcer base, and an adsorption of pepsin. All right, so this combination therapy has been shown to eradicate H. pylori in over 90% of duodenal ulcers and significantly reduce ulcer recurrence. And similar treatment is recommended for H. pylori related stomach ulcers. All right, so as we saw, histamine is one of those compounds, and perhaps we should go back to it. Where we saw histamine there playing, and the H2 receptor there playing a role in acid secretion. So it should be no surprise, therefore, that it is seen as a target, or as a target, right? And that is why we have histamine 2 receptor antagonists. So histamine release causes contraction of the smooth muscle in bronchi, in the GI tract. It increases permeability of capillaries, stimulation of sensory nerve endings, and strong stimulation of gastric acid secretion, as we saw. The vagal stimulation causes release of histamine from the cells in the stomach, acts on the receptors in the parietal cell, that's the H2 based on the diagram that we just saw, and then increases HCl production, which we saw as well. So traditional antihistamines and H2 receptor antagonists generally reduce the effects of histamine in the body, but they do not block histamine effects on gastric acid production. That is the traditional antihistamines that we take. The H2RA, which are your histamine 2 receptor antagonists that we're talking about, that class of drug was replaced as first choice drugs by the PPIs, and the prototype is cimetidine, and the structure is seen here. And it was developed by a classical structure activity study beginning with the endogenous agonist histamine. So essentially they use this as their model to start from, and then they designed a drug. As we can see, there are similarities between histamine and cimetidine. So cimetidine affects the cytochrome P450 drug metabolizing system in the liver, may cause confusion, and anti-androgenic effects. Essentially could lead to enlarged male breasts. The drug interaction potential and several adverse effects, as we mentioned just now, of cimetidine appear to be directly related to the presence of the imidazole group. So these limitations prompted additional drug design and development efforts, which reveal that the imidazole ring, which is in pink here circled, was not required for H2 antagonist activity. And so if you replace this ring with a furan, as was seen in ranitidine, not only does it enhance the potency, so ranitidine is more potent, and the selectivity was also enhanced, but it also reduces cytochrome and renal secretory drug interaction. So that was an improvement there. Because of the several side effects of cimetidine, they chose to make a change, and they found out that the imidazole ring was not directly responsible for the activity, and so they switched it out with a furan, and it worked wonders. All right, so here we have some FDA indications for anti-hypersecretory agents. So we just mentioned cimetidine and ranitidine, and there are others related to that compound. As we can see, the distinguishing tidines versus the prazoles, right? And your prazoles are your PPIs, and several indications for heartburn, GERD, various ulcers, etc. So these are the drugs that are generally prescribed for these ulcers or GERD or heartburn, etc. All right, so we have another question. Patients suffering from recurring ulcers are usually given a combination of 3 drugs. Propose a drug combination. All right, so you could choose any PPI. I have omeprazole here, but as we saw on this slide, we know there are several prazoles, and then we have 2 antibacterials, so tetracycline or amoxicillin, and clearly you could have selected other antibacterial agents. All right, so let's talk a little about proton pump inhibitors, PPIs for short. So they are strong inhibitors of gastric acid secretion, as the name suggests, proton pump inhibitor. They bind irreversibly to the gastric proton pump to prevent the release of gastric acid from parietal cells. They suppress acid secretion in response to all primary stimuli, including histamine, gastric, and acetylcholine. They are the drugs of first choice in erosive esophagitis or erosive gastritis, or as we saw, Zollinger-Ellison. They are more effective than the H2RA. They have faster symptom relief and faster healing using prevention of esophagitis, and the side effects include nausea and diarrhea. So it was in 1972 that a group of Swedish medicinal chemists discovered that certain pyridyl methyl benzimidazole sulfides were capable of functioning as the proton pump inhibitor that we now know. These compounds were subsequently converted to sulfoxide derivatives, which exhibited highly potent, irreversible, and we did mention that it is irreversible, inhibition of the proton pump. So the benzimidazole PPIs are actually prodrugs, and we know what that means, that the starter compound is not the active, the active is generated. And so they are prodrugs that are rapidly converted to sulfenamide and intermediate in the highly acidic environment of the gastric parietal cells. So the weekly basic benzimidazole PPIs accumulate in these acidic compartments on the luminal side of the tubovascular and canicular structures of the parietal cells. So the benzimidazole PPIs are then chemically converted by acid to the sulfenamide. So this is an example of your benzimidazole PPI here in terms of the structure or generic structure, and through a series of reactions in the cell, it is converted to your sulfenamide, which then reacts with your proton pump to form this irreversible covalent sulfur-sulfur bond with your proton pump and your benzimidazole PPI. So covalent complex with PPI and proton pump. So again, the benzimidazole PPIs are then chemical converted by acid, and we have acid here, to a sulfenamide intermediate that inhibits the proton pump by covalent interaction with the sulfurgyl groups with cysteine residues of the pump, that is the gastric proton pump. All of the PPIs have been shown to react with 16-813 of pump, but some bind to additional pump sulfurgyl residues as well. So for example, omeprazole and S-omeprazole also react with cysteine 892 and pantoprazole with cysteine 822 and lansoprazole to cysteine 321. To date, 5 structurally related benzimidazole sulfoxide PPIs have been approved by the FDA for gastric acid hypersecretory disorders. So we have seen a number of times omeprazole. You have S-omeprazole, that is the active enantiomers of omeprazole, and you have lansoprazole, pantoprazole, and rabeprazole. So this is the generic structure of your PPIs, and as we see X, Y, and Z as well as R. So those vary from compound to compound, but this is the general structure. All right. So as I mentioned, the PPIs differ only in the nature and degree of pyridine. So pyridine is circled in yellow, and imidazole, appropriately circled, ring substituents, as we see R and XYZ, which has an impact on the pKa values and therefore the pharmacokinetic properties. So the extent of initial PPI protonation, right? So if we go here, we see that the PPI is indeed protonated in this step. So the extent of the initial PPI protonation and thereby parietal cell accumulation is governed by the pKa of the pyridine ring nitrogen that ranges from 3.8 for lansoprazole and pantoprazole to 4.5 for rabiprazole. Thus, all drugs are believed to be concentrated at their physiologic site of action to a similar extent. So what's important here is that the rate of conversion of PPIs to their active sulfonamides, and just to go back to that diagram here, this is the prodrug and the active is the sulfonamide that reacts with their proton pump to form an irreversible bond with their proton pump. So the rate of conversion of the PPIs to their active sulfonamides, however, is determined largely by the pKa of the benzimidazole group, which we will label as pKa2. So pKa1 is the pKa associated with the pyridine, and pKa2 is the benzimidazole group pKa. So as a result of that, omeprazole, lansoprazole, and rabiprazole with higher pKa2s, that is, they range from 0.6 to 0.79, undergo benzimidazole protonation and sulfonamide formation faster than pantoprazole with a pKa2 of 0.11, right? So what is important here is the pKa of the benzimidazole group, and that will determine how fast the drug or the prodrug is converted to its active. How fast that literally happens. So you might be wondering at this stage, what is X, what is Z, what is Y, what is R? So as we said, they vary from drug to drug or PPI to PPI. So the X, most often is methyl. There's a methoxy there. There are a couple methoxys for the Y, or O-methyl, etc. For the Z, it's mostly H's, and then R, you have other functionalities as well. So we have pKa1 and pKa2 seen here. So in terms of the pharmacokinetic properties of the PPIs, omeprazole is 30 to 40% orally bioavailable, and we can see their metabolism, hydroxyl acid sulfide and sulfone. So there are several varieties in terms of how they are metabolized and excreted. So for the most part, 90% urine as metabolites. So for the most part, they are excreted as their metabolites. What else can we mention? So just to say here that, there's a variety of, based on the nature of the compound, the oral bioavailability varies, the plasma half-life varies, the metabolism varies, as well as the percentage excreted in the urine as metabolites. All right, so we have another question. Here is a list of PPIs and their associated pKa2s. List them according to the rate of conversion to their active sulfonamides. So here we have the list of PPIs and their pKa2s. So arrange them in terms of how quickly they are converted to their active sulfonamides. Pause and do that. All right, so if this is how you arrange this, you are indeed correct. Omeprazole, then lansoprazole and rabeprazole. As we can see, they have the same pKa2, and then the pantoprazole was the last. So it would be the slowest in terms of converting from our prodrug to our active. All right, so continuing on the pharmacokinetic properties of the PPIs, the duration of PPI anti-secretory action is determined by several factors such as the extent and nature of cysteine residue inactivated, the pump protein turnover, the activation of inactive pumps, and reactivation of inhibited pumps by endogenous reducing agents capable of breaking the proton pump inhibitor on that disulfide bond that was formed that we said was irreversible, right? So there are several factors that will determine the duration of the proton pump inhibitor activity. So PPIs that inactivate cysteine 822, such as pantoprazole, tend to have the longest duration of effect because this cysteine residue is on the pump transport domain. It is resistant to reductive reactivation and therefore requires replacement by new pump protein. Thus, pantoprazole has an effective half-life of 46 hours, whereas omeprazole is 28 hours and lansoprazole is less than 15 hours. So the significance of the differences in the rates of PPI activation or duration of action does not appear to have overwhelming clinical significance. All right, so let's talk a little bit about omeprazole, and that is the structure of omeprazole. And the X, Y, Z, and R are methyls and methoxy, right? Everything else is the same. What do we want to say? It's an off-white crystalline powder, very slight water solubility. It's an amphoteric compound. So it has pyridine nitrogen with a pKa of 4.06 and benzimidazole nitrogen with a pKa of 0.79. It's consistent with the proposed mechanism of action of the substituted benzimidazoles as acid labile, and hence the omeprazole product is formulated as delayed release capsule containing enteric coated granules, and these are polymer barrier applied to oral medication that prevents its dissolution or disintegration in the gastric environment. And continuing on omeprazole, the absolute bioavailability of orally administered omeprazole is only 30 to 40%, and that's related to how quickly it's biotransformed. As we saw, the drug has a plasma half-life for about an hour. Most of the drug, that is 77% of an oral dose, is excreted in the urine as metabolites with insignificant activity. The primary metabolites of omeprazole are 5-hydroxyomeprazole, and that reaction is catalyzed by CYP enzymes, and omeprazole sulfone. All right, so we'll see the image of those in the slide coming up after this. The antisecretory actions of omeprazole persist for 24 to 72 hours, long after the drug has disappeared from the plasma. And therefore, that supports the mechanism of action involving irreversible inhibition of the proton pump. So these are our metabolites of omeprazole. We have hydroxymethyl metabolite. So looking at the structure, we can see where we have a methyl group here and we have hydroxyl group on it. So this is one metabolite. You also have O-demethylation metabolite. So this methoxy here just loses the methyl, and so that's this metabolite. And then we have the sulfone metabolite here. So omeprazole, as we saw, is approved for treatment of heartburn, GERD, duodenal ulcers, various ulcers, and we need to look at the synthesis of omeprazole. So we have the pyridine portion and we have the benzimidazole portion, and we have clearly a substitution reaction going on here with your alkyl chloride moiety here and your thiol moiety here in the presence of base. So essentially this the base therefore would abstract the proton, and then this sulfur would be nucleophilic, attacking or electrophilic carbon here and releasing or pushing out, or would therefore lose our chloride ion, and we have a new bond between our sulfur and our carbon here. After that, methylchloroperbenzoic acid would basically oxidize the sulfur to form omeprazole. So fairly straightforward, fairly simple synthesis of omeprazole. All right, so this is our final question. Explain the mechanism of action of PPI. So that's the question that you will answer in class. So thank you so much for watching, and see you next time.